So the famous statement, children are not little adults, holds really true in trauma. Pediatric trauma is a pretty large topic, and so I'm going to try to focus on those aspects of imaging trauma in children that are a little bit different than what we do in adults. Trauma is the leading cause of death and disability in children and adolescents, and most of the injuries are going to be accidental, and most of them are going to be related to blunt trauma, but the minority of them actually involve the chest and abdomen, which is what we're going to focus on in this talk. The causes and effects can vary a lot, once again, between the age groups. Young children, you have to think about things like child abuse and in-home accidents. School-age children, it's usually recreational trauma, and teenagers, it tends to be sports, and even violence and suicide are pretty common causes of trauma in this age group. Now, there are some anatomical differences in children that affect how we image them and how we think about what trauma is going to cause in children. Their organs are larger, they don't have a lot of fat and connective tissue to protect their internal organs. Their bones are a lot more flexible. Their tracheobronchial tree is more flexible and is smaller and more easily obstructed. And their mediastinum is mobile, which can really affect how it responds in a traumatic blunt injury. So in the chest, with blunt trauma, the majority of the injuries that we see do tend to be related to motor vehicle accidents. And the mortality of chest injuries in children is really quite low, at least when it's an isolated chest injury. When it's combined with a head injury or an abdominal injury, then the risk goes up significantly. And most of the injuries that we see in the chest involve the lung, the chest wall, and the airway. The thoracic cage in children is quite flexible. The bones are less well ossified, and so they can bend and not break. They have a lot of cartilage in them. So when you have an impact to the chest, then that impact may not cause rib fractures, but may cause significant injuries in the lungs and even in the mediastinum and the heart. And so you have to look carefully for those kind of injuries, even without fractured ribs. When you do have rib fractures in children that are caused by an accident, they tend to be associated with other injuries, so be sure to look at the lungs, and even things in the upper abdomen like the spleen can cause injuries. Most accidental rib fractures are not very numerous, and they are usually unilateral. So if you have multiple bilateral rib fractures, you better have a pretty good mechanism described for that. Otherwise, you may be dealing with a case of non-accidental trauma, which we will talk about in my fracture lecture tomorrow. Pulmonary contusions, because of this compressibility of the chest, are quite common in children and caused by shearing forces. Many of these cases, there won't be any external evidence on the chest that there's actually been an injury to the chest. The chest x-ray may actually be normal for a while, so these contusions develop a little bit in the first 6 hours of life, and eventually you'll see some airspace opacity due to hemorrhage and interstitial edema. They tend to resolve spontaneously on their own over a week to 10 days, so they don't generally require much intervention, although occasionally in severe cases they can be complicated by pneumonia or by ARDS. Now, when we do CT for these lesions, I'm pretty sure we overdiagnose pulmonary contusion in children, because one of the things that you'll learn about the lungs in children is they collapse very easily. Their airways are very small and easily obstructed. So if you have a consolidation like this in the right upper lobe, but you see elevation of the fissure or evidence of significant volume loss, you may not be dealing with contusion. You may simply be dealing with atelectasis in many cases, and it's hard to know really sometimes from your CT. The more typical appearance of a contusion, though, will be a fluffy or patchy airspace disease in a lobe without a lot of evidence of volume loss, and you can be much more confident of the diagnosis of contusion if it has this appearance. The contusion and the associated pleural effusion or hemothorax that may be associated with it can sometimes obscure underlying pathology in that lung, as in this case, once the contusion started to resolve and the hemothorax decreased, we could see this cyst with a thin wall and a fluid level in it that represents a pneumatocele related to a pulmonary laceration. So these pneumatoceles are pretty common in children. They may be filled with air, or they may be filled with fluid or blood, and they may be related to a pulmonary laceration or simply to bronchiolar obstruction. And they usually don't cause symptoms, and they're self-limiting. Once again, they don't usually require any kind of intervention. And we tend to see these in trauma, but we see them maybe more frequently in other conditions, particularly infection in the lung. Necrotizing pneumonia is very commonly associated with these pneumatoceles. Tracheobronchial injuries are not that common in children, although pneumothorax itself is really quite common. Mostly they're going to be small and self-limited in children. True tracheobronchial injuries are really quite rare, and often those children don't survive to the emergency department to allow you to actually image them. Pneumomediastinum can occur related to trauma, but I actually see pneumomediastinum, particularly significant pneumomediastinum with large amounts of subcutaneous emphysema due to other causes, either a penetrating pharyngeal injury or often in a case of bronchospasm, as in this patient with an asthma exacerbation. So not a very common component of chest trauma in children. So chest CT, when should we do CT of the chest in children? Well, certainly CT is going to identify more pathology. There's no doubt about it that you will see contusions, pneumothorax, rib fractures, even mediastinal injuries much better if you use, and more frequently if you use CT. But studies have really showed us that any of the abnormalities that are going to require an emergent intervention are going to be seen on your chest x-ray. This study showed that they only had 12% of the children that had to have any kind of intervention for the findings. They were all chest tubes for a pneumothorax and one bronchoscopy for a big pneumomediastinum, and all of them were visible on chest x-ray. Also, those little occult pneumothoraces on chest x-ray that you can see with the CT almost never require any kind of intervention unless the patient gets put on positive pressure ventilation and gets much larger. So at our institution, our protocol is really that CT is only indicated in the chest after trauma for a high-risk mechanism and an abnormal chest x-ray. And if the chest x-ray is normal, we do not do a CT of the chest. So the pan scan of the body in children is not a thing in children. We really try to avoid that extra radiation that comes along with it when it really doesn't affect management in very many cases. But what about great vessel injuries, you say? Don't we have to worry about that? Well, they are pretty uncommon in children. Mostly we are going to see them in teenagers, in high-velocity motor vehicle accidents. Occasionally we'll see them in younger children if they had improper child restraints or were ejected from the vehicle. And like in adults, statistics tell us that the upper thoracic aorta is the most common location, and often, once again, these are life-threatening, and these children may not make it to your emergency department to be imaged. But if they do, the findings are very similar to what you would see in an adult. You look for mediastinal widening, loss of normal aortic contour, but we have some challenges in young children with those findings because widening of the mediastinum can also be related to the thymus gland. And this was a 6-year-old that we saw. I thought that this configuration of the superior mediastinum looked very much like thymus gland, but you expect the thymus gland to regress significantly over time. That's regression over time is quite variable from child to child. And so in this case, we really had to use CT to decide, is this superior mediastinal widening a hematoma or is this thymus gland? And in the end, it turned out to be normal thymus gland. So we do use chest CT for problem solving for mediastinal injuries. When I see aortic injuries in children in my personal experience, they're more common in the lower, in the abdominal aorta. And these are often related to impaction injuries and hyperflexion injuries related to seatbelts.